Greetings. Let us talk about ascites management, the role of dietary advice. I just want to thank many who support this program and take a couple of minutes to read this notice. When you see a patient with ascites in your clinic, especially after you've diagnosed it to be due to cirrhosis of the liver, then you have to figure out how to get rid of that ascites. And when it comes to that, one of the important management principles is to set up an, an appointment with a dietitian who can meet with not only the patient but also the patient's spouse so that both of them understand about the sodium contents of different foods. To just give you a rough idea, uh, non-vegetarian foods tend to have high sodium. Prepackaged foods in containers have preservative that is mostly sodium, again, high sodium content. And sauces tend to have high sodium. So, important to advise them and also to help them get into the habit of looking at the labels, the food labels, and focusing on the sodium content of each food when they're trying to buy at the grocery store. And when you think about sodium, it is well known that if you want to improve the global health, uh, sodium restriction has a big impact. As you know, sodium restriction cuts down the cardiovascular risk factors, especially hypertension. So it's important to educate them about the benefits of sodium restricted diet. It's also important for the patient to know about the salt balance and the imbalance that could arise that results in ascites. When it comes to an imbalance, uh, excess of salt tends to retain fluid and results in ascites in a patient with cirrhosis. And if you want to treat ascites in a patient with cirrhosis, you have to limit the intake or the input of salt into the body and figure out a way to increase the output or excretion of salt from the body. And this concept is very important for the patient to know. And when it comes to input, we know that you have to restrict salt. And how much should you restrict it to? It's about 88 milliculons per day of sodium. That is, for the sake of remembering, you can remember as 90 milliculons per day. That is equivalent to less than 2 grams of sodium per day. And if you want to convert it into salt, table salt, it's about 5.2 grams of salt. So if you restrict somebody's salt intake to less than 2 grams, and if their kidney function is in good shape and they're able to excrete between 70 to 90 milliculons of sodium per day, by restricting the salt intake, you could actually manage that ascites with dietary restriction. But dietary restriction has disadvantages. Low salt foods are not palatable. So, something to keep in mind while you're trying to balance uh, the nutrition versus the salt intake in the food. So, we talked about input. Let us talk about the output. So, when it comes to output, and how do we improve the excretion of salt from the body so that we create a negative salt balance, thereby allowing the patient to lose weight. And if your patient is on a 2 grams sodium diet or less than 2 grams of sodium per diet, and if the patient is able to excrete more than 90 milliequivalents per day in the urine, that automatically creates a negative balance, and the patient will lose the excess fluid and the ascites will resolve. So, this is probably true in patients with mild ascites with a relatively well compensated liver disease who can go on a salt restricted diet. But for the most part, being in a salt restricted diet for long periods of time is not practical. So once you advise them about input, output, sodium contents of food, how to prepare food, how to avoid high salt containing foods, and the importance between the input and output balance and creating a negative balance, how do you monitor whether you're effective in making the patient lose weight? So, in addition to the dietary advice, we should advise the patients to monitor their weight daily at a particular set time so that there's no variation uh, in terms of evening to morning, etc. So, when it comes to daily weight, uh, I personally prefer having the recording in pounds versus kilograms. As you know, a few pounds make a kilogram, and when you look at the weighing machine, it's much better to figure out if you are either gaining or losing weight when you have the scale set up to record in pounds. So, if the patient is excreting a good amount of sodium in the urine, you put the patient on a sodium restricted diet and you measure their weight loss over a period of time. Uh, uh, you should get into a negative balance. Unfortunately, majority of the patients cannot excrete the sodium. Uh, they tend to retain sodium because of severe secondary hyperaldosteronism. And in those patients, in addition to salt restricted diet or sodium restricted diet, we need to add a diuretic. And important to add a diuretic that counters the secondary hyperaldosteronism. And we're going to learn about the role of diuretics in patients with cirrhosis next. And I just want to thank the authors of this excellent guideline that helped me to prepare this review. Thank you.